is a big pleasure for me to welcome you to this session on blind spots and pain points in our work with the EHDS regulation, and especially we are going to talk about electronic health records in that context. I'm Lars Hulbæk, and I'm going to moderate this session, and I don't know how many of you had the pleasure to be in the plenary session this morning. Please raise your hands. Some of you, I won't tell. It will be between you and me. A lot of you did, and I'm happy. And because I think that Petra Wilson, she talked about this European health data space as a dream. And I think perhaps we should keep that in mind during this session too, because now we are going to talk about how to realize that dream when it comes to especially the electronic health records and the data exchange. And I think we all agree that this will be a long and winding road, but we will all work to realize that dream. So the outline of our session, well, yes, here we are. We have this panel. We have a great panel, and we have panelists with different roles in healthcare. And I think that is also what this thing is about. It's about cooperation. It's about different angles to the subject. We have from the providers, we have Mariam from HIMSS in the Netherlands. We have from the industry, Jörg from Compo Group Medical, Germany, and we have from the public sector, Juha from the Finnish Institute for Health and Welfare. So please welcome our great panel. So just a few words about me and my organization. I'm the CEO of Medcom, and we were established way back in '94. And ever since then, we have been dealing with taking international standards down, making national profiles, and implement it in the whole country. And somehow, this is also what we are going to talk about right now in this topic about European health data space and electronic health record systems. That is basically what we have been doing for the last 30 years in Medcom. And some of you might know that things are happening in Danish healthcare right now. We are facing a huge reform as the healthcare sector as such. And a part of that reform is also reforming the way we work with the digitalization. And a new organization will be formed in Denmark called Digital Health Denmark. And this will be a joint venture between the existing organization, Danish Health Data Authority, our health portal, Sundhed.dk, and Medcom, and some regional systems too. So we will build a new healthcare digitalization organization together. We have 2026 as a preparation year, and then from 2027, we will be in full action. Enough about me, enough about Medcom, because what the topic really is today is this ETHL working paper on the European health data space. Because now we are, as I said, we are going to make this dream happen, and we see some pain points and blind spots that we would like to address and we would like to discuss with you. I'm happy to see so many people here because we need you to make this paper even better. So I think that when we look into this this paper, just to give it a few words, I think that we see, of course, that the European health data space has introduced this regulation of a new category of products, European electronic health record systems. And what we have seen, what we have learned, is that it seems to be a quite broad definition. There's a lot of systems, a lot of different systems under this umbrella. And from our point of view, from the point of view in the paper, it will be difficult to kind of make it all happen at once. So we see that we need perhaps to be a little more, have some more nuances in this discussion. And that is one thing. Perhaps the definition of the electronic health record system is too wide in the regulation as such. And we would like to discuss that and the impact of that with the point of view from the three different sectors that we have represented in our panel today. So we try to recommend how to address this issue, and we will get back to that. And then again, I can't say it enough, during the session we would very much like you to give your point of view on this issue too. So, I think that we could use the time best by leaving a lot of time for our panel, and I think that it will be a pleasure for me to welcome you, Mariam, to take the floor, and please.
Yes, thank you so much, Lars. How many of you had a very good coffee today in the morning? Good breakfast? How many of you are patients? Can describe yourself as a patient? How many of you are healthcare professionals? Pharmacists, doctors, clinicians, physiotherapists, nurses? Okay, great. So we have wonderful people in this room, and you had a good coffee, so that's a good start. So my name is Mariam Shokralla. I am a digital health strategist in HIMSS. I'm a pharmacist and a public health specialist by training, and I have been working in this space in a very different international context, but now focus on the Netherlands in so many different capacities before. In the coming 7 minutes exactly, I would like to spark some conversations about the EHDS definition as it is, the electronic health records definition as it is in the EHDS. And when we started to map from the vision, which is a wonderful vision that's mapped in the EHDS, and I used to do a lot of policy work before, now I'm more in the implementation side. And then you try to match it to the reality, you start to realize that the gap between the reality and the regulation itself is a little bit big. And all what I'm going to share with you is in the context of my day-to-day work in HIMSS, in which I go and visit hospitals in the EMEA region, in the Europe and in the Middle East. On a day-to-day basis, I evaluate the adoption of the electronic health records in these hospitals. I actually just came back from a 3-week trip in Italy, in which I visited almost 12 of the most mature hospitals in Italy, looking at all of their electronic health records, their CDSs, how they actually use technology to allow better and efficient organizational and patient outcomes. So let me start here. When we talk about electronic health records as it is in the European health data space, I'm going to read to you the exact definition as it is in the regulation itself. It's any software, any system whereby a software or a combination of hardware, this software allows personal electronic health data that belong to priority categories of the EHDS or established under the regulation to be stored, intermediated, exported, imported, converted, edited, and reviewed, or by any intended by the manufacturer to be used by healthcare professionals who are providing patient care or by patients when they access their electronic health records. Now, this is the binding definition of what an electronic healthcare system that's going to be regulated through the EHDS. When we look at the reality, actually there is 3 definitions of the systems that we operate at the moment. And I want to differentiate between them because that will have some implementation implications on how we think about whether countries, how they adopt EHDS, or even individual providers, how they are going to adopt EHDS. So there are electronic medical records. These are the electronic medical records, the templates that's used in the hospitals itself, in which clinicians for the first time enter your health data. This is mainly needed for clinical documentation and workflow optimization inside the hospitals. Usually, this is in one organization, so a hospital would use InterSystems, another hospital will use Epic, another will use Cerner, another will use Daedalus. So there is so many providers in the market, and there is also national providers. Usually, these electronic health records will be in the national languages of the healthcare system of these countries. Then we have electronic health records. This is not electronic medical records. This is electronic health records. So this is, sometimes it exists in countries. So this is sometimes is a national architect. So a single patient record that aggregate the data for every patient from whatever provided that has this data has been created into one specific single repository linked to that patient. Now, we all come from different countries. How many of you think, because you're patients, you are consumers of your healthcare systems, how many of you think that you have actually an access as a patient to your electronic health record? A one single sign-in where you can see all your data from whatever provider where this data has been created. How many of you? Can 2 or 3 shout out the countries where you're from? Finland, great. Where? Estonia, great. Front runners. Belgium as well, okay, great. Israel, okay. Macedonia, okay. So in that record, you would be able to see all your data generated in primary care clinic when you visit the GP, and also whatever hospital you have been in, right? Great. Would you be able to add data if I have a wearable, if I have a glucometer at my home? Would you be able to add data there? Who say yes? Which countries are they? Belgium, Israel, Finland as well. Anyone more? We lost Estonia here. Okay, so Estonia have what's called as an electronic health record, but they don't have what's called personal health record. This is when you extend the amount of data that's in this system, not necessarily the clinical data generated by clinicians when you are in front of them in an episode, to your person-generated data, whether you're using a wearable, a self-management tool, I am taking my blood pressure every day. So that's where I am a patient, can contribute my patient-generated data, and hopefully that will integrate somehow to my clinical-generated data when I'm in an official episode in a hospital or in the GP, and together can help whoever make decisions for myself, whether me as a patient or the clinician, to into my clinical decisions. At the moment, this does not exist a lot in so many different countries. Why I'm focusing on this? Because in the EHDS, it also enables citizens to add their person-generated data to be mixed with their clinical-generated data, and hopefully give a much better, complete image about you as a patient. Now we need to think which systems actually enable this at the moment. Think about it as a patient. Aside from that, we have also departmental systems. So every hospital, inside the hospital, you have imaging department, pharmacy department, labs department, and usually all of these departments will bring together whatever generated from one patient into a clinical data repository, and that's why when it is projected through the the clinician interface. So when you are in front of the clinician having a visit, then he would see all your labs, all your images, anything that has been generated about you within the hospital, because all of that data in the different departments have been aggregated on the hospital level in the CDS. Why I'm going to the extent of explaining this, I'm just trying to give you how many systems with a different scope and a different type of data, and almost a duplication of the data. So all of these systems can, based on the definition, if you map that to the definition of the electronic health systems in the EHDS, all of them can store, intermediate, export, import, convert, edit, and use for the health data. So all of these systems with this wide scope is actually under the scope of the EHDS. Now, I'm a very pragmatic person, and I like to start to think about, okay, how we're going to adopt to EHDS. It's a beautiful regulation. It gives me the chance as a patient to have all my data in one place. What we need to think as different stakeholders. First of all, I said that all my data exists first in the departmental level. So if I have an MRI, it exists in the PACS of the hospital, but it also exists in the CDR, which is the aggregator for all of the data on the hospital level. Then the question is, when we do the exchange format, whether the data is going to flow from the departmental systems only directly to the format, or it's from the CDR itself, which already aggregate my data to the format. Which system is going to produce the format, which is the main product of the EHDS? The second one, we already now have all patient portals. So every hospital you used before as a patient, you already have a patient portal where you have access to your data. But I will speak about myself in the Netherlands. If I use the 3 hospitals, I will have 3 portals. Every portal have a data about the type of episodes I had in that hospital. And I also have a portal in my GP. I don't have a one portal that aggregate all this data on a national level, because in the Netherlands, we don't have a single patient records. So in reality, I am, as a patient, have access to my data, but it's fragmented in all of the patient portals I have access to. Now these patient portals are under the regulation of the EHDS, so they have to comply with the EHDS. But then the question is how we leverage the data there, which already flow from the hospitals or the GP systems, to be part of the EHDS. Or it is going to be a duplication, basically. So that's another question. The third one is, as I just said, some countries have this single patient record where it's an aggregator architect on a national level that aggregates your data from whatever system on a national level. And you just have an access as a patient on that single patient record. Now you need to think, then the data is going to flow from that already aggregated single patient record, or still have to flow from the hospital itself, from the primary care, from the PACS system in the hospital that you have used. The fourth one is all of the primary categories of the EHDS, which is labs, images, patient summaries, discharge reports. They happen in hospital, so hospitals generate this type of data, but also primary care generate type of data, especially in countries where primary care is the gatekeeper for the specialist care. So you have to go to the primary care to actually be referred to specialist care. So now the question became bigger. Now the primary care became under the scope of the EHDS. When you look at the maturity of electronic health records that's used in the primary care, it's really far behind. It's going to be a very long journey for primary care records to actually be able to share the data in a standardized, coded, and computer-readable way as the EHDS expect. So I'm going to end up here. And this is why the biggest recommendation, there are 4 recommendations in this paper, and the biggest recommendation that I really stand for is how we clarify the scope of the EHDS based on the definition of the EHRs as it is in the regulation. And I'm not talking about going back and changing the regulation itself from a legal standpoint of view, but we need to clarify this so we can breed clarity as we start to implement and think who should adopt this regulation. And I will end up here, and I'm very curious about your question. Thank you so much.
Yes. Thank you so much. And I think it was very clear for us how many types of system we see underneath as soon as we dig one time. You touched a little upon the primary care sector. In Denmark, that would be both the GPs, the private specialists, but also the municipalities having responsibilities within elderly care, rehabilitation, health prevention, and so on. And I think that what I understand from you is that is also a part. So if we dig even deeper, we will see much more EHRs.
Yeah, so the main governing factor is whether you are, as a provider, produce any of the priority categories. That's the EHDS at least to start with. Now, of course, the regulation gives the countries the ability to expand voluntarily the amount of categories that need to be shared with the EHDS. So for example, you might ask yourself, if you are a dental care if you are in elderly home, so if an elderly home have an electronic healthcare record that they use to maintain medication management for the elderly housed in this home, actually this system should bring this data to the EHDS because it's going to be part of the medication list. How you produce a complete picture of the medication list of that patient unless you bring that from the elderly home records. So now you can see that even it's not the traditional as before electronic health records used in the medical care, but it will be extended to the social care, which is managed usually by municipalities in different countries, which is going to be even much more challenging.
Thank you so much. We will move on, and now we will leave the floor to you, Jörg, to give us some views from the point of view from the vendor. So please, the floor is yours.
Thank you so much. I hope you can hear me because I've lost my system, so I think everything should work. Thank you so much, Mariam. I think we have found a common ground, and I don't have to repeat so many things, and it's so detailed, and everybody here in the room knows that it's quite a very complicated issue we talk about today, this morning. So before we dive into Europe's health data opportunity, let me briefly introduce CGM. We are a family-founded company. CGM, Computer Group Medical, is one of Europe's leading digital health companies. We provide software, services, and integrated solutions for healthcare providers across Europe, from hospitals to outpatient care. Our mission is very simple: connect healthcare data, improve care, and enable better outcomes for patients and providers. With tens of thousands of institutions and millions of patients supported, we're at the forefront of Europe's digital health reality. So let me make it clear, Europe is very good at proclaiming turning points, but far less successful at implementing them. We here in Europe invent, others scale. Photovoltaics, for instance, is one example. Health data must not become the next one. Not because Europe lacks ideas, not because we lack talent, but because we often lack speed, consistency, and strategic determination. Europe is poor, we all know that here in this room, is poor in natural resources. But it possesses something far more important: ingenuity, intelligence, creativity. This is Europe's true resource. And in the 21st century, with all its shifts, look at Davos today. We don't know what will happen. But with all these shifts, this resource must be connected with what has become the new oil: data. Europe possesses the largest coherent health data space in the world, around 400 to 450 million electronic health records. Neither the United States nor China has anything comparable. And this is not just a technical asset. It is a strategic resource of global importance, and it exists only here in Europe. We must not allow this treasure to be exploited elsewhere, not out of isolation, not out of mistrust, but out of responsibility for our patients, for healthcare systems, and for Europe's technological and economic sovereignty. So, the greatest risk to this treasure does not come from outside Europe, In my eyes, it comes from within. At the center lies a very concrete regulatory uncertainty, the definition of what constitutes an EHR system under the EHDS. We all know here in this room the definition is broad and functional, but in practice, its boundaries remain unclear, especially for modular systems, for what we try to produce, add-ons, registries, analytics, and AI applications. This uncertainty is not academic. It directly affects compliance strategies, product development, and investment decisions across the industry. Rare diseases, as one example, expose this problem particularly clearly. Overly rigid regulation risks making data formally available but practically unusable. So our goal must not be regulation for regulation's sake, but enabling regulation. A framework that builds trust, protects patients, and at the same time enables innovation, value creation, and scale in Europe. For industry, including CGM, this creates concrete challenges. Now I come to the pain points. Unclear technical standards force early investments from our side with risk of rework. Regulatory burden and liability shift responsibility onto software providers. Thank you. Secondary use requirements impact core clinical workflows, risking acceptance. Development, testing, and certification generate significant costs without clear funding. Interoperability requirements must satisfy EHDS, now I come to your speech again, and national coding, billing, and reporting standards. So to overcome these, industry needs two things: secure legal access to health data and workable, trusted interface. And let me be clear, and that's what my colleagues always used to say to me, we need pseudonymized data, not anonymized. It's a big difference. Only this enables meaningful research, learning systems, and AI in medicine. Let me give you a concrete example. A recent study from colleagues in Singapore analyzed over 1.28 million electronic health records. By systematically reusing existing data, researchers identified additional cases of the so-called Fabry disease and increasing diagnosed patients by 50%, which is quite a lot. But they also find, not talking about only rare disease, but they also find over 12,000 previously undiagnosed cases of high-level cholesterol. And this is quite important. This is not a future vision. This is proven progress made possible by data. Imagine what becomes possible if Europe unlocks its full health data treasure, earlier diagnosis, more targeted therapies, and far more efficient healthcare systems. But this will only happen if industry is granted secure, reliable access to pseudonymized data. Behind every data set is a human being. We all know that. A family, years of uncertainty, doctor after doctor, without answers. Every year without a diagnosis for a person with a rare disease is a lost year in life. With a truly usable European health data space with secure and trusted pseudonymized interfaces, we can end those lost years. We turn data into diagnosis, diagnosis into hope, and hope into life. this is not a technical detail, because we talk quite a lot about technical details. It's a human imperative. When we unlock Europe's data treasure, we unlock Europe's future on health. Thank you so much, and I'm really looking forward to answering your questions. Thank you.
Thank you so much, Jörg, and I'm pleased to hear that you share the dream. And thank you for leaving space for some questions. I can see the walking microphones from here. I can't see any hands, though. Oh, look here, over here. And please, name and organization.
Stefano Dalmiani, Monastero Foundation, Italy. So I totally resonate with the statement that perhaps we need to work with the pseudonymized data, but here we have some kind of clashing with GDPR that requires to manage patient consents and so. So what might be a solution, since the EHDS might seem to solve this, but really don't? So what might be a solution for this, by your point of view?
So thank you very much for your question. I hope that I understood you right. So, you know, the very huge difference between anonymized and pseudonymized data is that with pseudonymized data, there is a curtain between the information of the patients and between and between the data, of course. Yes, so there is a curtain, and there is a code, and you can come back to the patient if you want. So you can recognize patterns, of course, and that's not possible if you only use anonymized data. This is not possible. So in my eyes, this is the solution. Of course, I come from Germany, and we all know that, in the Netherlands as well, and in other states in Europe, always talking about data protection. And this is very important to protect data, of course, but don't be afraid. So usually we don't go in this direction, so that we try to recover who's the person, who's your date of birth or your name or nothing like that. But we have to see the patterns. This is very important. This, in my eyes, this is that's the reason why it's so important to use pseudonymized data in opposite to anonymized data. And yeah, I hope I answered your question correctly.
Thank you very much. Give a hand to Jörg. And I think we have to move on, but we will have perhaps time for further discussion later, because we have to hear from the public sector too. And Juha, a part of the organization running the cancer system. So we need your point of view on these pain points, and the floor is yours.
Thank you, Lars. So nice to see so many of you, and thanks to Ethel for inviting me to be part of this panel. So my name is Juha Mykkänen. I work as a chief specialist in Finnish Institute for Health and Welfare, which has many roles. We are a national research institute. We do statistical things. But part of the tasks we have in the regulation is also national steering of health and social services information management. I work in that part of the organization. So we do have several national agencies. So I'm not covering all the public sector. I'm not covering all the publicly available service provision. For example, we had a huge renewal in 23 in Finland in the health and social services. And each country has these, and we have to really also bring EHDS and as part of this changing landscape in each of our member states. So I mainly bring a national viewpoint here. I'm also involved in the development of the national infrastructure in Finland, the steering on national level, but also in some of the European projects and groups who have been working around EHDS regulation. But on national level, we have had some quite similar aspects to EHDS and the regulation of systems. In Finland, for health and social care information systems, have had some national regulations related to the essential requirements of these systems for more than 10 years already. So we have experience in some of the things that are there also in EHDS. We have a registry of systems with more than 300 registered systems, according to the definition in the national regulations, of course. And we have a third-party external certification for the most critical systems and those systems that are connected to our national infrastructure. Those things we don't have in the EHDS. In EHDS, we just have the registration and the self-testing of systems by the vendors. So there are differences as well. But it's still a product regulation. The vendors, the manufacturers, are in key position in finding out which requirements we must fulfill. But we also have a responsibility of user organizations to make sure that they are using systems that can actually connect to the national infrastructure, that are actually fulfilling the requirements set to different types of systems. So there are similarities, there are differences, but many of the things that are there for EHDS regulation have been there. For some countries, Finland is not the only one. Some other countries have had very similar types of regulations on national level previously. So this is just an example from one country. And some of the things we can observe in EHDS, and especially the interoperability part, the electronic health record exchange format, is that, okay, we do have this very wide definition of EHR systems. But within that definition, like we heard, there are many different kinds of systems and a very, very wide variety of different systems. Functionally, in terms of size, in terms of intended users, in terms of the context that the systems work. Some are clearly meant and the purpose is to be used as a small integrated part. Jörg mentioned modularity, which is every day for most of the systems that we are using all the time. We have now the regulation, but it, of course, doesn't have and shouldn't have all the details. There's lots of very, very good work on interoperability around the new format in Europe, done by standards organizations, done by the joint action projects, and lots of people are working on that to realize really the promise we have around the defined priority categories, and so that we can have joint specifications to make it happen real time. But that's not all. There are many, many, many details we need in systems in addition to that. So specifications are needed between the regulation and the implementation to realize the vision. There is no single EHR system that does all parts of the priority categories. Pharmacies are different from the prescribing functionalities. The internal systems and specialized systems, like we heard, only deal with some parts of the priority category, while adding lots and lots of more details for a specialized use, etc. The data content and use cases of the format have inevitably some national and local flavors as well. We heard about billing, reporting, and the connection to the actual health services system that each country or canton or federal state has. We must be able to support evolution. So we know that things are evolving, and in the regulation itself, it also envisions this. It says that, okay, these are the first priority categories, but there might be more coming. Even within the priority categories, we might see that, okay, we had something in the first version, the capabilities that can be expected to be implemented are at this level first, but it should be incremental and progressive. So that's part of the things. So we also need flexibility. We need modular reuse. The regulation talks about harmonized components. So a component is a reusable piece of software and hardware for interoperability, for logging. And the flavors of these components really depend on the purpose of use of the system as well. And of course, it's impossible to upgrade everything at once. We all know that. The EHR systems are not standalone, so modularity, which Jörg also mentioned, is quite important. So, looking at the the white paper and the recommendations, in the white paper, we tried to reflect some of those, probably also already in the previous slides. But the refinements are clearly needed within the wide definition of the EHR systems for different types. Of course, part of it must be that these are the parts of the exchange format we are handling in each of our systems. But in addition, there are other things that need to be declared and clarified. Is this system meant for professionals? Which professional groups? Which specialties? Is it general use? Is it for primary care, secondary care? Is it just some internal system? These kinds of things are actually part of the intended use of the system as well, in addition to which data it handles. So we need to be able to acknowledge that. And the exchange context of data, for example, whether it is internal exchange between some departmental systems and the main systems within a hospital, where you can actually then also say, okay, we have this hospital level things for security and login and identifiers and things like that, which you then not always have when you go cross-organizational. So we have to be able to support both types of exchange. So the exchange context is quite important. We already heard that the regulation for the sake of regulation is not the goal and shouldn't, of course, be. EHDS is a very important enabler for many other things. And data quality and the usability and burden for professionals, we must always keep in mind that we don't accidentally produce bad quality data or increase the burden of the professionals. If you're interested in that, there's a very interesting paper by the Nordic Council of Ministers where the Nordic countries have actually given some thought for these points as well. So enabling these kinds of things is very important as well. And we know that there are very, very many technical details when we approach the implementation and deployment of the EHDS and the systems. And some small details at first may become big burdens and hurdles for the implementation unless we can actually identify them and then also say that, okay, this is how we should jointly solve some of these. So what we must have is, of course, continue coming together, have this kind of international collaboration, but we need it on many levels. We need it on policy level, we need it on technical level, and I hope we can have it also to some extent on clinical and infrastructure level, learning from each other and learning from what has been already done. We must be able to do the national requirements and fitting the general EU level regulations to each of our national contexts. And we may need to be able to utilize what we already have. For example, in Finland, we aim to be able to support many of the requirements of EHDS through the national Kanta infrastructure, which already has the national connection point for cross-border information exchange. It already gathers lots of data from central systems, from all public healthcare organizations. The social services are joining also this year. And there are these hundreds of different systems which have already been doing lots of interoperability work, on top of which we must be able to build. So those are some of the key points. I think some of them are related to the recommendations of the white paper, and I'm looking forward to very interesting continuing discussion. If you're interested, we have at THL, the Finnish Institute for Health and Welfare booth in the exhibition floor, and I will be there at least at 12:30 if you want to have more discussion on these aspects. But first, let's go with the panel continuation. Thank you.
Thank you very much, Juha. And I think we have time for a question from the audience. I see one familiar hand.
Yes, hello, I'm Michael, come from Medcom in Denmark, and I very much appreciate this diversion or categorizing of different IT systems. I quite agree. And behind any big EHR system, there's an amount of smaller IT systems, and in my opinion, those should not be in scope of compliance with the regulation. But my question is about standards, because is the standard a standard, or are there different types of standards? And in my opinion, we have the logical data models and the requirements, and they are not as static as the regulation text. But we also have another category of standards which are very much technical. And in my opinion, we should look into how is the governance about these different types of standards. Who should have the governance of the logical expression of how we share data, and who should perform or have the governance of the technical, more flexible standards, which are those standards we are implementing in the IT systems. How are your opinion about, or take on that?
Yeah, that's one of the key points, I think, for realizing the interoperability promised by the EHDS. And there are models for that. I think the Finnish model is so much that there's one institution who has a mandate to say that what goes in the logical models and what the code systems should be. And then there are others who have mandate. I'm saying mandate because this is very important. A mandate, when we are talking about regulation, the mandate is important. There's another organization to do that. But the expertise for technical standards, I'm happy that we have very close involvement of organizations like HL7 and IAG as part of the refining specifications for EHDS. And for logical models, there should be always a view and the evaluation of value of each data element. And the challenge is there that the value of data elements is very much, in some cases, dependent on the use case. So to find very generic things, we may come up with what the standards already have, very generic base standard, but then refinements for more specific use cases. And this has already been done by many of the standards development organizations. I think this approach is needed here as well.
Thank you very much. And as I promised you in the beginning, we now really need your help, because we need to find out, we need your opinion now on how important our recommendations in this paper actually are in your point of view. And to do so, we will have a voting as the last part of this session. And now you need your cell phones to scan this QR code. And while you do that, just let's repeat the four main recommendations from the paper. We have discussed the scope of the EHR systems. It should be clarified. We have discussed that for some of those types of those EHR systems, We perhaps think that the timelines should be relaxed for implementing standard, and we need this appropriate governance for the processes around updating and retaining these standards. I think that was what you were touching upon, Juha, too. And another kind of governance, the overall governance for EHDS, how should this practical work with the standard influence the overall EHDS governance? So that's the four main recommendations in this paper. So I think we should move on and have a vote and look into recommendation number 1. You could please just don't read the headline, but also the 3 lines below. Is it working? Yes. I see some, yeah.
Question.
Yeah.
Now,
oh.
you mean EHR and not EMR, or are they mean the same, both in this case? Sorry. Yeah, so clarifying question. EMR or EHR? I mean, it says EHR, but how about EMR? No.
Yes, but as you heard from Mariam, that was her point of view, that we have this umbrella definition on EHR, and underneath you have, for example, EMRs.
Okay.
So here the question is, how important is it that we should be more clear about the definition? So thank you for for asking that question.
If you allow me, the EHDS, yes, no, so I'm Luc Nicolas from ETEL, sorry. Well, we try to look at the regulation from a functional point of view. So having a definition for EHR is fine, it helps, but basically we have the format and we have the data included in each of those formats. And what I think we need to have that in mind is it's exactly that today, which is at stake. So some people will produce a full format, and a number of other systems just will produce a few of the data included in those formats. And that's where I think the confusion is coming, because I think we don't need to have a definition for all systems. We just need to stick to that.
Thank you very much for that opinion, and I think that one thing is definition, but I also think what we have in mind, being quite practical people sometimes, is that the task is huge, and where should we begin this journey? I think that's perhaps why we need to discuss the diversity of the IT environment.
Yeah.
But thank you. So it looks like there's some kind of...
we don't see it on the screen.
Sorry.
So
no, I don't know.
Yes, here we go.
Okay.
Disagree.
We have some strongly disagree. Do anyone want to kind of fold out that opinion? We won't hurt you. We're here to learn.
Anyone?
That's okay. I think we will move on, so you can. Yep. And I must say, I'm no longer in charge of the slides. So thank you so much. Back there, because we have to move on to keep time to recommendation number 2, where we talk about the time slots, perhaps this priority discussion, and please vote.
Do you agree? Do you think we need more time?
I think I'll just leave this here. And then we might, in a few moments, see how your vote is going on. Yeah, look, oh, this is much more diverse. Yes. We still have some strongly disagreements, and again, please feel free to tell us why you strongly disagree on this recommendation from the ETHL. Yes, we have one finger here.
Thank you, Michael. Well, the timeline was already relaxed since, I don't know, in the last 20 years. So perhaps it's also too late to work on some kind of common global EHR at European level, but let me say also at national level. So this is my point of view as an hospital.
Thank you. We need to listen to the hospitals.
Yeah, Lars, I actually really agree with you because I think we have been a little bit complacent a lot about how we use the data and how we even generate reusable data in our health systems for quite some time. And now I would like to differentiate between vendors who kind of say, oh, because we don't have a clarity on whether our solution should conform with the EHDS and should produce a priority or not, then we're going to be relaxed and let them discuss, and then we're going to see what happens at the end. I think this level of complacency is really not acceptable, and it is harmful for patients. But if we think that all of the vendors really try to engage with the practical question that need to be clarified on how you're going to comply, how you're also going to align your compliance with national data governance structure that already exists in every country, and I would assume that the roadmap of every country is going to be different, but then by the nature of the complexity of this challenge, you would need more time. That's a different story. I can understand this. But if we just need relaxed time because we say, oh, it's such a big challenge, we do not know how to start to tackle it, then I think this complacence should never exist in our industry. And everybody, even on an individual level, should try to think about it, and this is why these type of the conversations is very important. So I fully agree with you.
Thank you.
Thank you. Let's move on, and now we are running out of time, but we have to talk about governance too, and now we are talking about the governance for the standards as such, how to manage the update, the maintenance of the standards. And we want your opinion on how important you think that it is. And in a few seconds, we will see how you voted. Now look. A lot of you think that this is quite important. Thank you. And because we are running out of time, I can hear the coffee machine. I think that we need to move on to recommendation number 4 and have your opinion on how these more technical details should influence the more overall EHDS governance. How important do you see this if we should reach out for the EHDS dream? A little more diverse, but still quite important. I think I hear you. Let's build some bridges between the practical work and the overall governance. I think we got a quite clear picture from that. So, thank you so much. Thank you for your contribution. Thank you for being an active audience. Thank you to our great panelists. It has been a pleasure to be a part of this session.